pleasure for me to introduce today's speaker, Dr. Helen Bevan. Helen has been a leader in healthcare change for more than 20 years, and she's been at the forefront of NHS improvement initiatives for a number of years, and these have had a significant and positive impact for thousands of patients. Helen is acknowledged globally for her expertise in large-scale change and the ability to translate that change into action. And in 2008, Helen was recognised as one of the 60 most influential people in the history of the NHS. Helen initiated the NHS Change Day in March 2013, which saw the biggest ever collective action of change ever seen in the NHS. You will all have been given a couple of post-its when you came in, and you're probably wondering what these post-its are for. What we would like you to do is to make a pledge today of how you are going to change in a positive way where you work. Now, we've got you 2 post-its because we want you to write the same pledge twice. Once to stick on the board that you'll see outside the lecture theatre when you leave, and one for you to take home. And Helen will mention a little bit more about this pledge during her lecture. Many of you will know that Helen is an avid user of social media, and with over 13,000 followers on Twitter, we clearly aren't the only ones who are interested in what Helen's got to say. Now, if any of you here today use Twitter and would like to tweet about today's lecture, it should have been our hashtag. If you could use the hashtag Stirling Health, and you can tweet about today's lecture, so feel free to do that as we go on today. So without further ado, could I ask you to join with me and welcome today's speaker, Dr. Helen Bevan.
Thank you. Thanks, Ashley, and well, it's good afternoon, isn't it? So we're going to spend about 50 minutes now thinking about being a change agent in health and care. And like Ashley says, I've been a change agent in health and care actually for nearly 25 years. And I think, the essence of this is how can we rock the boat? How can we be the people that when we see practice that is poor quality or not safe or giving our patients bad experience, how can we be the people that stand up and challenge the status quo and make things different, okay? But do it in a way that we rock the boat, but we manage to stay in it. So that's the theme of my lecture. Okay, let's start off with this figure, okay? 70%, okay? When we're thinking about change in healthcare and more generally, why is that figure of 70% a key figure? When people are talking about change in healthcare, people mention this figure quite often. Anybody have an idea? Want to have a go?
Improvements or changes that don't stick.
Very good, very good. So the mantra, okay, is that about 70% of change efforts generally fail to achieve their objectives, okay, about 70%. And what's interesting to me as somebody who studies large-scale change and thinks about it a lot, if you go back 20 years, there were articles in Harvard Business Review saying 70% of change initiatives don't work. I'll show you some of the most recent analysis from 2014 by Gallup, and it says 70% of change initiatives fail to get their objectives. So in 20 years, okay, nothing's changed. I'll show you some data now. This comes from McKinsey, so it's got to be right. And this was a study that McKinsey did with 3,000 leaders of organisations across the globe. So private corporations, healthcare, education, government, not-for-profit sector. And the leaders across multiple sectors, multiple countries, okay, all reported the same thing. What they showed was that only about 25% of change efforts, okay, get anywhere near achieving their objective. And the reality that was reported is it's nearer about 5% of change initiatives where the person leading the change actually, or the group or the organisation delivers the change, sustains it, and moves on to the next phase of change. So I guess our question is, what do we need to do to at least be in the 25% and ideally in the 5% and certainly not in the 70%? And you know, I've just spent a fantastic morning actually with a group of final year nursing students, and we've been looking and learning about their quality improvement projects, okay? Just so inspiring. And it's interesting sometimes, you know, when you're on a project, like here I am with my quality improvement project, and I'm cycling along, and here's my goal, and I've got a really, really clear aim for my project. So what I have to do is I have to, you know, have a clear aim, and use good methods and stay focused, okay? You know, often that's how we want it to be. But when it comes to change, the reality is much more like this. You know, so what do we need to do to lead change and deliver change successfully in this kind of world? This is a reference here from a guy called Peter Fuda. How many of you have come across Peter? Has anybody read or know a little bit about Peter Fuda? Okay, he is based in Australia, and he is a thinker, researcher about big change. And afterwards, if you want to, you can download this paper here, Why Change Efforts Fail. But again, he's talking about this topic of the 70%. And what he says is that, you know, why does it happen? And he says that there are 5 flawed assumptions, okay, that leaders or change agents make when they're going about change, okay? The first one is that change can actually be managed. That, you know, we can create a change management system or a program plan, or these are our 8 work streams for change, and that we can kind of manage it from the centre. The second, that when it comes to a change initiative, that human beings are objective. And again, I'm just working with the students just a little bit earlier, and we were talking about oral hydration and how important it was. And yet, everybody accepts, you know, that oral hydration for patients in an inpatient hospital setting is very, very important. And yet, you know, we fail to comply consistently following the processes that keep patients hydrated. So, you know, the idea that people are objective, that they'll look at that standard and say, yes, that's a really important thing to do, and yet the follow-through doesn't happen. The next flawed assumption is that there are X steps to change. And again, any of us that go and look at change management literature, there's all sorts of models, okay, where there's like the 8 steps to change or the 7 steps to transformation. We'll look at one of those in a moment. The next is that we have a neutral starting point for change. So that, you know, when we're in a change situation, it's almost like there hasn't been any history, or people haven't done things before or tried them and they've failed before, okay? There's never a neutral starting point. And finally, the 5th flawed assumption is that it's the change itself that is the goal. You know, so if we could make this change happen to the way that we support frail older people, then you know, great things will happen. Okay, but you know, the change isn't the goal. The goal's the goal. You know, but what we keep doing is that we keep treating change as if it's the goal. Okay, doesn't work. Okay, I said I'd show you some recent research. This comes from Gallup, and it's a study that they published in February about why 70% of change efforts fail to achieve their objectives. And what they found that was really interesting was that the biggest issue was about what happened to messages as they went down the organisation. So if you're up here, if you're the senior leader in the organisation, the director of nursing or the chief executive, you know, this is like, these are the 10 priorities of our organisation, and we're really clear. But as we go down the organisation and we get to the front line of care, there are more and more and more priorities. So people at the front line don't know what the actual priority is, so they're trying to kind of make sense of it. And the trouble is that when the people at this end, okay, change the priorities, often the people at this end don't know. So we're just adding more and more and more priorities. And it's interesting because this Gallup research was done from a kind of generic perspective across industries. And then just a few weeks ago, I found some more very interesting research that is coming from the USA, which was published in Health Affairs, and it was called The Dangers of Quality Improvement Overloads, Insight from the Field. And basically this was saying exactly the same thing, but in a healthcare context. It says, if we have our goals for quality improvement, but the buy-in from our frontline teams is absolutely critical to change. And we won't get that buy-in if we overload our frontline employees with many, many, many different priorities. So, if we want big change to happen, we have to keep those messages very clear. Now, a lot of my work is about looking into the future and saying what is going to happen in the world of change. And what I've tried to do on this one slide is to contrast the kind of dominant approach in organisations to change and what is the emerging direction. Now, what's important about this is not from to, okay? That many aspects of this dominant approach are alive and kicking and will remain. But there's this emerging direction coming as well, okay? And we need to be able to work with both. As agents of change, we have to work with both. So on this side, okay, power comes through hierarchy. I have positional authority. Where I am in the organisation, my status determines how much power I've got. So if I'm the chief exec, I have lots of power. But if I'm a staff nurse or, lo and behold, a student, I have got no power at all. I am the lowest of the low. That's how often it can feel. Whereas on this side, power comes from connection, Power isn't about who you are in the system. It's about how good you are at connecting and networking with other people. On this side, we talk about the mission and vision of the organisation and having an organisation that has a really clear, vision of how we want to be for our patients. But, in the world that we're moving into, mission and vision isn't enough. And we also need to think about shared purpose. When we think about working in different ways, engaging our patients, our families, communities, other organisations in the wider context of which we work, mission and vision isn't enough. We've got to build a massive sense of shared purpose. On this side, we make sense through rational argument. So, our thinking is data-driven. We use planning systems. And on this side, we make sense through emotional connection, because you see, if we're working in this way, which is about connecting, networking, linking up, then people will do that because of making an emotional connection, okay, rather than because of a rational case. When I went to improvement school in the NHS in England a very long time ago, I got taught that if I wanted to influence a medical doctor to get involved in change, I had to show them a graph, okay? Because doctors were only influenced by data. Well, guess what? Even doctors are far more likely to be called to action and to get involved in change because we make an emotional connection than because of data. And obviously, we want the best of both worlds. We want some really compelling data and then building a kind of call to action and an emotional connection around it. Here, when we talk about innovation, it's top-down driven. So again, my context, the NHS in England, the chief exec of the hospital system will say, we've got to take £60 million out of our bottom line next year, and we're going to do that by improving quality, and we're going to innovate. So off you all go and innovate, okay? So it comes kind of top down. Here, the innovation is much more, grassroots, bottom up, and viral. Our methods here are very tried and tested based on experience. And again, when we look at the quality improvement methods that our nursing students here are using, okay, they're fantastic. Those methods are very powerful. They've been around for a very long time, and we know they work. But I'd also say that isn't enough. And we also, in a world that is where we're becoming increasingly connected, where I can reach out and I can connect with virtually anyone, anywhere in the world, 24 hours a day, with very little cost or effort. These open ways of thinking, okay, not just inside my organisation but outside, means that we're having to start to think in very different ways, you know, sharing ideas and data, co-creating change. And so one of the things that I did recently was I ran a virtual school for change agents, and it was called the School for Health and Care Radicals. And we had 1,600 people from 40 countries around the world that took part in our School for Health and Care Radicals. And on the 4th of July, we're having a graduation ceremony. Well, obviously, these students, you know, the graduates, they're all over the place. So they can't come to a physical graduation. So we're running a virtual graduation in a virtual world. Okay, we're running a graduation ceremony in Second Life. Okay, so I am being taught to do this, and I am being taught by a 15-year-old. You know, and it kind of takes a bit of getting used to, but it just really strikes it, you know, because here I am, you know, the change and improvement expert, and in this world, I'm being taught new skills by a 15-year-old. You know, it's great. And then finally, in this world, you know, we talk about transactions. And again, certainly in my system in the NHS in England, a lot of the change has been very transactionally driven. You know, it's about holding people to account for national targets. It's about performance management mechanisms. It's about contracts and commissioning. And all these things are transactional. We're holding people to account for a transaction. But here, okay, it's about relationships. It's about how we connect with each other. It's almost like on this side, not all, but a lot of the thinking, okay, is about, you know, you have to do it. It's the system, it's how we've set it up. On this side, it's about we want to do it. We're getting engaged because it really matters to us. And as change agents, as boat rockers, you know, we need to be able to live in both worlds. I just want to show you a couple of pieces of research and thinking that are really influencing me at the moment. Who's read this book, Leading Change by John Cotter? Has anybody read this book? Okay, yeah, great. So the thing about this book, it was published about 15 years ago, and it's the #1 influencing book in the whole world about change. Okay, it's written by this guy, John Cotter, and basically he says, if you're the head of an organisation and you want to radically change your system, you have to follow these 8 steps. Okay, remember going back to Peter Foudet and the X number of steps? But basically, if you the leader of an organisation, you follow these 8 steps, you'll get better change outcomes. Okay, and it's like how we create a sense of urgency, we create a guiding coalition for the change, we develop a vision and strategy, we communicate the vision, and so on and so on. Okay, we can really tell that the world is changing because John Cotter now says this doesn't work anymore. Okay, and for the great John Cotter to say that, things must be happening. And about 3 weeks ago, John Cotter published a new book, and it's called Accelerate. And what he basically says is that leaders, organisational leaders, can't create big change in a top-down way through hierarchy. It just won't work anymore. Because, you know, when you think about a hierarchy and the way that we typically organise our healthcare systems, they're designed for division, you know? They're designed to kind of split us up and keep us in our little compartments. And it's very kind of practical and obvious and positive, actually, because it's about getting the work done. But, you know, it separates us. It keeps us in our silos. And it's designed for division. And, you know, very often we even describe our organisations in that way. So the division of general practice, you know, the medical division, the specialist surgical division. Okay? And what John Cotter says is that it's just not a viable mechanism on its own for delivering big change, because the nature of hierarchy is that it is inherently risk averse, and it isn't quick enough, and it isn't pervasive enough. Okay? And what he says is that we also need to think about networks. And as an organisational leader or a leader trying to lead change, we've got to think about hierarchy, and we've got to think about network. And, you know, how do we work in informal ways that kind of bring network leaders through? And the implications of this are really significant. Okay? The first thing is that it's no longer can we just have a few change agents, you know, the quality improvement leader, the organisational development facilitator. We need to have lots of change agents with lots of acts of leadership. What he also says is if we don't get at least 50% buy-in to a change, don't even bother trying to do it, okay? Because if people haven't bought into it emotionally, informally, then it isn't going to happen. How many changes do you think there are in healthcare where we actually stop and we get at least a 50% buy-in before we make the change happen? You know, maybe not that many. But he says the days when, you know, we come up with an action, oh, you know, we're going to have a new change approach, a new quality improvement strategy for people with dementia. So people living with dementia. So what we're all going to do, we're going to like rush off and take the action. This is what's going to happen. Okay, can't do that anymore. We need to think about who are the people that are going to be affected by this or be part of the change, and we've got to get at least 50% of them to buy in. What this also means is no longer can we just have change based on you have to do it. You know, targets. Performance management approaches, compliance mechanisms, okay? We've got to move to have to want to. If people don't want to do the change, it isn't going to happen. And he talks about the spirit of the volunteer, you know, that as leaders, we should be treating everybody as if they're a volunteer, okay? One more I want to show you. This is an article that appeared in Harvard Business Review, July and August 2013. And it's called The Network Secrets of Great Change Agents. And what it's about is, you know, how to be a really great change agent, effective change agent in an organisation. It's written by two Canadian researchers, Batalana and Casciaro. Okay? What these two researchers did is they went into a major organisational system or set of systems, and they followed 68 change initiatives around the system, and they used that to work out what made a great change agent. Does anybody know what organisational system they went round? The British National Health Service. Okay. They didn't specify it was just England, so I presume it was Scotland as well. So they basically followed 68 change initiatives around the NHS and worked out a few things. And it's a really great article, but there was two particular things that I wanted to stress to you today. The first thing is that when it comes to being a great change agent, it's very little to do with positional authority. It's very little to do with how high I am in the pecking order. Okay? Being a great change agent, or the factor that makes the major difference, is where I am in the network. Okay? And what it means is that there are frontline staff nurses, there are students, okay, who are fantastic and effective change agents, and in fact better change agents creating more change than people at the top of the system, okay? So where you fit in the informal network is more important for being a change agent than where you fit in the hierarchy. The second thing that I think is really interesting was they said, if we want to create change on a small scale, incremental change, okay, which is a good thing, okay, then work through what they call a cohesive network. And when we talk about a cohesive network, it means being in a network with people like me. So it's, you know, so if I'm a GP, I'm in a network with other GPs, or peer-to-peer change, with nurses, or manager to manager. But being in a cohesive network means I'm connecting with and I'm working with people that are like me, you know, who've maybe had a similar education to me, have had similar experiences to me, and I would trust. Okay? And that's great for making small-scale incremental change happen. However, if we want to create big change, which many of our organisational leaders do, we have to move beyond cohesive networks, and we have to link with what they call bridge networks between different groups. So if you want to be an agent of big change, okay, connect up people that currently aren't connected. Okay. And certainly in England, what I see happening a lot are a lot of leaders that are trying to create big change through cohesive networks, you know, and the research suggests otherwise. So, you know, if we want to be the great change agents, if we want to be the people that stand up and challenge the status quo and build informal networks, even when often we haven't got any positional authority, okay? That makes us a heretic or a radical, a rebel, a maverick, call us what you want, okay? But often when you choose to be that person that stands up to make change happen, you know, you choose to make yourself different. You know, you choose to challenge the status quo. So when people do that in organisations, do they typically have a nice life? No, okay? This is what I think often happens. So, you know, in a sense, if we're going to be the people, okay, I mean, there's good news. The good news is that, you know, we should be confident about being change agents, because actually, even if we don't have hierarchical power, it doesn't matter, because we can build our power in other ways. However, having said that, you know, when we choose to be the person that stands up, okay, that stands up against the current system, often, you know, we can have a very tough life. And yet, if we look back in history, every new truth, you know, begins as a heresy. And, you know, what do we mean by that? That, you know, many of the ways that we're talking now about how, you know, care closer to home, or, you know, care in communities, like even 15, 20 years ago, that was a heresy, okay? Because so much of the power was with big hospitals, and hospitals were expanding and expanding. And now we're recognising, you know, because of the financial situation that we're in as a health system, and also because it's better for people, that we should be moving care much closer to home. But that was, even though that's kind of our new truth, and everybody accepts that now, okay? A few years ago, it was a heresy. And in a sense, we have to be the heretics, you know, we have to be the people that are saying, actually, there's a different and better way of doing things. Because big things, important changes, only happen in organisations and systems because of heretics and rebels and radicals. And I really like this cartoon. This is Galileo, and he has got all these like amazing discoveries. And he's discovered, you know, that the Earth is a planet, and there are other planets out there. And through his telescope, he can see the craters. And he's trying to explain his findings to the church establishment. And this person here is the representative of the church establishment. And all he can think about is repressing Galileo. And I know how Galileo feels. And, you know, in a sense, what we need to be boat rockers. You know, we need to be these people who can rock the boat and stay in it as change agents. And, you know, people that are successful boat rockers are able to walk a very fine line between being different and fitting in, being both inside and outside. And, you know, great boat rockers are able to challenge the status quo when we see that there's a better way. And what very, very successful boat rockers do is both conform and rebel. So, you know, we support our organisation and its patient-centred mission, okay? We really want great things to happen to our patients, and we're conforming to help that to happen. But we're rebelling at the same time, because lots of things in our organisations aren't right. But one of the key things about successful boat rockers is that we are able to work with others to create success. We're not destructive troublemakers. So I'm just going to show you a little table, then I'm going to let you have a chat with the person next to you. Okay. This comes from a really, really great website called Rebels at Work. It's worth looking at that. And again, it's an organisation for boat rockers from across the world, from lots of different organisations. And what they do very helpfully is make the distinction between a rebel and a troublemaker. So let's look at the difference. Okay? A rebel is, like, you know, creates new things, supports the patient-centred and person-centred mission of the organisation. You know, is passionate about the kind of future we want for people that use our services. You know, as a rebel, I'm optimistic and hopeful about the future. I generate energy in people around me. I attract people to me. You know, I see lots of opportunities and potential, and I'm able to work in solidarity with other people. Okay, so we come together. That's very different to being a troublemaker. Okay, troublemakers complain and whinge a lot, but the nature of the complaint is about me. It's very me-centred. So the injustice of my situation, the unfairness of what's happening around me. And typically they're very angry, they're very pessimistic, they're not hopeful that the system can change. They sap the energy of people around them because they're complaining and they're so negative. And so therefore they alienate other people, they see problems rather than opportunities, and very often they're alone. Now, I have spent my entire career being a rebel, okay, or trying to be one. But a lot of the time, okay, other people will see me as a troublemaker, okay, because they don't see the difference. The other thing that happens is there are a lot of people, particularly clinical colleagues, nurses and doctors and therapists, who start off being rebels and having a real sense of calling and wanting to make a difference. But often they end up working in very difficult, toxic environments where their voice isn't heard. And they cross the slippery slope from being a rebel to being a troublemaker. So I'm going to pop that table back up, but I want you to just think about some of the implications of that, okay? What are your insights around rebels or radicals and troublemakers? Which are you? What moves people down that slippery slope from being a radical or rebel to being a troublemaker? And how do we protect against this? So I'm going to give you about 3 minutes. So say hello to the person next to you if you don't know them, and have a little chat about troublemakers and rebels. This framework, again, comes back to Peter Fuda and the work that he's been doing around what makes a transformational change agent. What are the characteristics of change agents that are able to deliver radical change? And he talks about these characteristics on 3 different levels. He talks about a change agent like being change. Okay, this is about me and who I am and how I operate in the world, and the extent to which everything I say and everything I do, puts across that I am a person who is passionate about quality improvement. The next level up is about seeing. And this is, standing back and looking at a situation and getting a sense of, what is really going on here? Could I look at this situation in different ways? What is the reality? Okay. It's interesting to me. So, very often we'll do process mapping or value stream mapping, which is a great way of understanding what the steps are in a patient journey step by step. But then when we go and observe it, the process, actually what we see is very different, because what people say they do and what they do are often very different. So it's about, seeing. And then finally, it's about doing change, and that's about having the skills and methods for creating change and enabling improvement. When you think about change agents in the NHS, okay, which one of these 3 do we mostly focus on? Yeah, doing. I'd say that most change agents in healthcare settings in Britain focus on doing change, and what I'd say is that it's where most change agents in health and care will put most of their effort, doing the change, making it happen. So, I've been given responsibility for this change project to take out the weights in the emergency room, so I'm going to go off and do my change. Okay? And it's what other people will typically judge us on. So, I might be told, Helen, we want you to do this new project, okay, around getting wheelchair access for everybody in England, and you've got 6 months to do it. And I will be judged on whether or not that project gets delivered in 6 months. So of course I'm going to focus on doing. And it's what we most often perceive we need to do to add value. And very often it's the doing aspects that improvement courses and change courses will focus on, methods and tools and techniques for change. And doing is important, of course it is, because if we don't do the change, we won't get the results we need. But but what Peter Fuder's research shows is that what makes the difference about being a really great change agent is not just being a doer, okay, but also seeing and being change. So we need to think about this. So all of us that are doing quality improvement projects, it isn't enough to do the quality improvement. We have to be the quality improvement, and we have to see it, okay? So we can only do effective doing if we build on these very strong foundations of seeing and being. So part of being is to say, change begins with me. And it's very easy, to go into a community health setting and to go around and observe, what's happening in terms of people with leg ulcers, venous leg ulcers, and be very critical. There isn't a proper standard, or people aren't doing things right. It's very easy as a change agent to say, you need to change, and that needs to change, and that needs to change, as if the thing that we were changing was an external reality out there. Actually, change begins with me. So before I can tell anybody else to change, I have to think about how I need to change myself. Okay. And it's about seeing possibilities, hope for future, potential, looking at change from many different ways. But it's also about seeing myself in the context of my higher purpose. So, why did I decide to be a nurse? Okay, why did I decide to be a doctor? Okay, what's my bigger purpose in doing this change project? So let's talk about being. This comes from Aldous Huxley, and he says, there's only one corner of the universe that you can be certain of improving, and that's your own self. So we can't be certain of improving anything else, but we can improve ourselves, and that's a good place to start. Okay. So thinking about this, what we've got here, okay, based on evidence, 5 things we know about successful boat rockers. Okay, in terms of people that are able to lead change, really well, rock the boat in their organisations, but definitely stay in it. What do we know about them? I'll start from the bottom. We know that they're more likely to see obstacles as challenges to overcome and to kind of stick with it and be resilient. The next thing up, okay, they're able to achieve small wins, which create a sense of hope, self-efficacy, and confidence. And this morning when I was looking at the student projects, just seeing all those small tests of change for quality improvement the students are making, absolutely spot on for being a great boat rocker. I'm able to join forces with others to create action. And, nobody can be a boat rocker or a radical on their own. Okay? It's a very, very lonely life. The only way that we will succeed is if we link with other people. But the key thing I wanted to focus on now is about this sense of self-efficacy, because when we look at the evidence base around being an effective change agent, this issue of self-efficacy is almost like the most important issue. So self-efficacy means the extent to which I believe that I am capable of leading and delivering this specific change. Okay, because basically, if I kind of I have to do a project, or my manager asks me to do a project, and I don't really believe I can do it, then the chances are I won't do it. So, let's just think about this self-efficacy issue a moment. So, it's interesting this morning because in the student presentations, we heard about Albert Bandura and learning theory. And the great thing about Albert Bandura, or one of the things, is he's like the father of thinking about self-efficacy. And he says, the ability to act is tied to a belief that it's possible to do so. So if I believe I can do it, it'll happen. If I don't, it won't. And Henry Ford, the motor guy, he was writing about this 100 years ago, and he understood it even then, because he said, if you think you can or think you can't, you're right. So as a change agent going into change, think about this. And again, just a summary, there is a positive, significant relationship between the self-efficacy beliefs of a change agent and his or her ability to facilitate change and get some good outcomes. So it's really important. Okay? What's the difference between the term self-efficacy and these 3 other terms, self-esteem, self-belief, self-confidence? Anybody want to have a go? Want to have a go?
Humility.
So humility, it's linked with humility. Anybody else want to rise to the leadership challenge of having a go? Do you want my version? Yeah, okay. So these other 3 terms they're like general terms. So, she's very self-confident, or he's got, high self-belief, or high self-esteem. The thing about self-efficacy is the context, okay? Self-efficacy relates to a particular context or situation that I find myself in. So in terms of the quality improvement project that I'm doing around supporting people with diabetes, okay, it's the extent to which I believe I can deliver that particular project. So here we have the hot dog sausage, who I think is a man, and he's saying, hey everybody, I am awesome, okay? So that's not self-efficacy, that's the other thing. Now, as Ashley said, one of the things that I've been very involved in is NHS Change Day, where this year on the 13th of March, we've got 800,000 people pledging to make a change. We did a previous Change Day in 2013, and in the learning evaluation, one of the things that we looked at was what stopped people making changes. And you know, the biggest issue that came out was this issue about permission. And we're saying, you know, go on, pledge, make a change in your area. And people were like, oh, I don't think I've got permission, even to make a small change. So one of the things I'd say about this, what's the actual issue here? You know, is it really an issue about permission? Oh, I don't feel, you know, in the circumstances around me, I can do this. Or actually, is it about self-efficacy, about how I feel myself? And I think very often it's this, you know. I mean, it's probably a bit of both, because it's a complex situation. But we keep thinking it's an external thing about, oh, you know, it's the environment, there's too much compliance, too much regulation, too much inspection, and it stops people feeling, you know, that they can do things. And, you know, but actually, a lot of this we can work on ourselves. So, you know, how do we build self-efficacy to be great change agents? The first thing is about investing in our own development as change agents and improvement leaders, because we want to create the conditions where we can succeed better. Secondly, we create change one small step at a time, and that is why you know, rapid cycle, plan, do, study, act cycles and other similar methodologies are great for enabling that to happen and building self-efficacy. Number 3 is about reframing our thinking. So instead of saying, oh, you know, that project didn't work, it failed, you just said that was a fantastic learning opportunity. And if you feel, oh, I don't know if this will work or not, I'm uncertain, actually that becomes curiosity. Make change and the learning cycles from change, make it routine. So don't just make, you know, a cycle of change something you do for your university project. Build it into the way that you work every single day. Get social support. Don't surround yourself with a load of troublemakers. Okay? Surround yourself with people that are also passionate about change and want to make it happen. You know? Learn from the best. So, you know, like, who are the best people in Scotland you could learn from? Okay? Phone up Jason Leach and say, will you be my mentor? You know, just ask. I mean, all people can do is say no. And then finally, get people whose opinion you value to encourage you. And find your own mentors, okay? Because very often, you know, we have mentors and supervisors because it's part of our job and part of our training. But, you know, could you have a change mentor, an improvement mentor, okay? Because it can make a real difference. So my call to action to you, okay, is just thinking about this and thinking about being a great change agent. You know, too often we think, I can't do this, I haven't got permission, I haven't got power. And yet the evidence tells us really clearly it's very little to do with that, actually. It's about me and who I am and how I operate in the world. It's getting organised with other people. You know, it's building my own self-efficacy. You know, work out how to rock the boat and stay in it. And, you know, we don't have to kind of go blundering forward and shouting and screaming about change. You know, we can rock the boat really effectively and like maintain our position of where we are. And think about how you build your own self-efficacy. So, like Ashley says, one of the things we wanted you to do, you know, think about, in this context of yourself as a change agent, is to make a pledge on your little post-it about a change that you'd like to make, okay? And you know, prove to yourself and prove to other people around you that you are, you know, a fantastic change agent, okay? So maybe we'll give you a little minute now just to write down on in your post-it. And again, like Ashley says, to write it on 2 post-its. Okay? What change will you self-efficaciously make? Self-efficaciously make. And I just want to end with a poem. And this is one of my favourite poems about being a change agent. And it's called Outwitted, and it comes from Edward Markham. And he says, "He drew a circle that shut me out, heretic, rebel, a thing to flout. But love and I had the wit to win. We drew a circle that took him in." And you know why I like that poem very much is because you know, here I am as a change agent in healthcare, you know, really passionate about making a difference for patients. And I can see some of the things that need to change. But when I stand up and I have the courage to say those things and start to get organised, other people will actually push me out for challenging the status quo. But you know, if I can build love, if I can build a sense of shared purpose, if I can connect with other people because we want the same things, then we'll draw a circle and we'll bring other people in to our great change efforts. So I hope you had some great pledges. I hope that's given you a few ideas, and really happy now to take some questions.
Slides, I was just sort of, it was almost reenacting the meeting that I left before I was liberated to come up to Stirling University. So, and in some of our discussion and listening to the discussion, it doesn't actually even matter where you are in terms of, because some of those slides I've got that power thing, and actually I feel like that so many times within my world. So it's just incredible. It's lovely to have the time. We've got about 10 minutes for questions, and I know you'll have some incredible questions. We've also got a roving mic. I've got one of these Foghorn Leghorn voices, so I'm sure you'll hear me. But any questions first? Yeah.
Hello, I'm Lorraine Armstrong, Clinical Academic Fellow. Helen, I just wondered how you felt about being my change mentor.
Okay, well, I'll tell you what, do you know one thing? In this life, you have to ask. Do you know, I went on a learning program at Harvard with a guy called Marshall Gans, who is he's like a community organizer, social movement thinker, and he's the guy that was the architect, the intellectual architect of Obama for America, that changed how political organizing happens in the US. And one of the key things he taught us, you know, you've got to ask. And like we're often really, really frightened of asking because somebody will say no. So actually, I really applaud your courage to asking in public, and also it kind of puts pressure on me now.
Or stupidity.
So I want to make an offer to you, which is that I've actually got, because I mentor a lot of people, what we do now is that we've got a mentees group and we mentor each other. And there's 7 people in my mentees group, and there's like the medical director of a region in Canada, there's a Norwegian academic, there's an NHS graduate trainee, there's a director of a mental health organisation, and we all mentor each other. So if you would like to join our mentoring group,
fantastic.
We'll have you.
Will do, thank you.
So that's what you get for asking.
Hi, I'm Jane Donaldson. I'm a Professor of Nursing at Edinburgh Napier University. I'd just like to know what you think, Helen, about rebels and their risk of burnout, and is there any top tips that you could give some rebels in the room?
Yeah, so have I got a pen? Can I write on something? Oh, here. Right, whiteboard marker. So can I write on this? Okay. So, you know, this is such an important question, because if you look at, again, back to the 70% figure about why large-scale change efforts fail, okay, typically what happens, they run out of energy. You know, they will go so far and then they just don't go any further. So actually focusing on energy for change for the long haul is a really critical question for change leaders. So thank you for asking it. So we've been doing some really interesting work recently, and it's talking about different kinds of energy. So can I just show you this for a minute, because I think it's interesting. Okay, so and I can leave you a reference to all this work. But basically, what it says is that if we want to keep energy for change for the long haul and stop people burning out, we need to think about 5 different kinds of energy. And so the first kind of energy is social energy. And social energy is the energy that's about connections, partnership, collaboration. When social energy is very high, there's a real sense of us and us rather than us and them. Okay? The next energy is spiritual energy. And spiritual energy is the energy of looking to a bigger future, a higher purpose. When spiritual energy is strong across a whole organisation or a whole team, then people will move much more confidently to a different future because they've got a sense of a vision and where we're trying to go, and we buy into it. Okay. The third kind of energy, and I can never spell this, if I spell that right, psychological energy. And psychological energy is the energy of feeling safe, feeling willing to put my head above the parapet and try out a few improvement projects, where psychological energy is low, people don't innovate, don't want to take a risk, fear retribution. Okay? The fourth energy is physical energy. And physical energy is the energy of implementation, action, making things happen, getting them done. And then the last energy is intellectual energy. And intellectual energy is the energy of thinking things through, planning, rationalizing, being logical. Okay. So we've tested about 1,500 healthcare colleagues, mostly in England, but in other places as well. And the results are pretty consistent. In most healthcare organisations, okay, particularly ones that are involved in change projects that are trying to reduce cost and improve quality, which of these energies do you think is most dominant? Physical's quite good. It's intellectual. So many of our healthcare organisations, and I bet you it's the same here, are driven by intellectual energy. So it's like, we've got these big improvement targets that we've got to hit, and these big cost reduction targets that we've got to hit. So we're going to do a big plan, and these are the accountabilities, and these are the work streams, and we've got to follow this through. And it's almost sheer intellectual energy. And you know what I'd say? Am I being filmed? I could want to say this, but. Okay. There's a lot of people in a lot of places that are trying to transform healthcare through intellectual energy by having big plans. And the problem with intellectual energy is that it is not transformational because it's intellect to intellect and it keeps people in their comfort zone. What we see, and why you were right about intellectual energy, what we see in a lot of places, and this is me getting around to eventually answering your question, is this combination, very toxic combination of physical and intellectual energy, very, very prevalent in many healthcare organisations. And basically it's, these are the goals, this is what's got to be achieved, we're holding you to account, off you go, make it happen now. And often, when we talk about burnout, we talk about change fatigue, what we're seeing is that combination. And very often, in energy terms, what we've got to focus on, I think, is the social and spiritual energy. So, how do we kind of create a sense with spiritual energy, a sense of the future that we're trying to create? Why are we doing this? And social energy, working with each other, working together in solidarity. And what happens is you can see two organisations, and one of them is actually in a much more dire financial situation than the other. But because they've got strong social and spiritual energy and the leaders have built that, you don't hear words like burnout or change fatigue. Where there's other places where, there's these kind of energies are very prevalent, where, people are just exhausted. And it's just, initiative on initiative on initiative kind of push down the organisation. So, I'd say, find the people, if not in your organisation, around you, that you can build the social energy with. Find the people that you can build, the spiritual energy with, because it will just make a huge difference.
Hi, Dave Simpson from the School of Management. Can the head of an organisation be a rebel?
Oh yeah.
And are there any conflicts of interest?
I know loads and loads of rebel chief execs. Because the other thing I'd say is that you're often like, you might be the chief exec, but you're in a bigger system, And so I actually think, looking at the John Cotter stuff, I think the best senior leaders are the senior leaders that combine, using the levers of change and build networks effectively. I can think of actually loads. What makes them stand apart is, being very driven by values and convictions, and everybody knows that. Okay, creating the conditions where people can come up with really great ideas, and building lots of social and spiritual energy. Being a rebel is really very little to do with where you are in the hierarchy. And you can be a rebel as a student, or you can be a rebel as a very senior leader.
Hi, I'm Mary Wells. I'm a Professor of Cancer Nursing Research and Practice in the NMAP Research Unit in the school. I suppose I'd just like to hear your thoughts on the place of research in the NHS at the moment, particularly given the sort of huge focus on quality improvement and the tensions, I think, that exist between quality improvement and research. And just like to hear what you think about that and how we overcome some of those tensions.
So it's like, what about the relationship between quality improvement and research, and the role of research? So I would never ever embark on a major change programme without commissioning research as well, because I think we, in a sense, we have to kind of capture knowledge. We have to understand what worked and what didn't work, and we have to take it to the next stage. So I think, very often in quality improvement, like, our focus is, how do we make a difference? Often in research, it's about new knowledge and creating that. But like, for me, it's about how the two come together. And like, personally, I always try and work in ways that are very evidence-based, or taking account of latest thinking. I think that very often there's a gulf between the research community and the practitioner community, and I think that there's things that have to happen at both ends. In a sense that I think as improvement practitioners, we need to get much better at working with the research community, building some social energy, actually both those things, and guiding the research community around the kind of research that's going to make the biggest difference. I know people in the quality improvement movement, quite well-known people, who never commission research, because they say, the research is, it's not yet suitable or sophisticated enough to take account of what we're doing. But I just think if you take that attitude, you will never get there. So we have to work together. And it's also about the research community, like, really listening in and working in different ways with the practitioner community. But I think there's all sorts of interesting and wonderful possibilities moving forward. I want quality improvement to not be an afterthought or a bolt-on. I want quality improvement to be hardwired in to the kind of work that we do every day, and a core part of people's jobs. And I want improvement methods to be built in to the way that our organisations do business at every level and at every stage. But I'm a rebel as well. So I want to be using quality improvement tools to work with my fellow band of rebels, like, working in really informal ways. I mean, it's like NHS Change Day. 800,000 pledges. Okay, did anybody give permission for NHS Change Day? No. Did it have any resources? No, but we managed to find some. Did it take quality improvement forward in our country a long way? I hope so, and we're evaluating that now because we're in the process of commissioning research. And I think it's about, where the two come together. So I think that it's not, I think too often we confuse like quality improvement with compliance and make it part of the compliance regime, and I think often that's where it goes wrong. But I think that if it's part of a wider process of the commitment-based change in our organisations, that everybody gets a voice in, and we've got the kind of informal changes going on in the side, then I think that's the best of all worlds. Yeah.
Hello, I'm Lisa Sutherland. I work for NHS Education Board for Scotland. I was interested in your slides about communication to the front line and organisational structure. Designed for divisions, and the NHS I think is designed for divisions with silos. How do you feel that that could be improved in terms of communication, and what's the role of kind of digital technology to enhance that? Because it still feels a little bit archaic. Yeah, and I think that obviously we want to communicate better through the cascade, okay? And I can just see, some of the chief execs that, for instance, that I know that are working with digital communication really effectively, and people like Mark Newbold at Heart of England Trust, or Sarah Jane Marsh at Birmingham Children's Hospital, whereby they've just created the most brilliant situations in their organisations where like anybody in the organisation can connect with them, through social media, and they're working in really open and transparent ways. So definitely, the opportunity to like the cascade, in a sense, the hierarchical system. There's so many ways that we can connect people directly that overcomes those issues. And then I also think in terms of the network side of things. And just major opportunities to communicate and connect informally as well. And I think it's about both.